Hello, this is Harpswell Coffin, and I am going to discuss attention deficit hyperactivity disorder today. So here goes. I'm going to start with Jimmy. He is a 21-year-old white male diagnosed with attention deficit disorder at age 8. And I just want to say, as a side note, that every resource that I used discussed ADD and ADHD all as ADHD. So, and they considered ADD as a type of ADHD. So that's just a little side note, which I think is strange because some of them don't, some people don't have the hyperactivity aspect, but they're still considered ADHD without the hyperactivity. I don't know. Anyway, so he has ADHD. He was diagnosed at age 8. No comorbidities or allergies or other medications except to treat his ADHD. He does have a family history of ADHD. His 3 older sisters, he's the youngest, and 2 of them have it. He's also the only boy. He grew up in Boston, and he grew up with devoted parents, but being the last kid, was left without guidance, and they kind of just put him down in front of the TV and told him to calm down. But he always felt like he had more energy than he knew what to do with. Felt cooped up. He was from the inner city. There's no nature or backyard, very small one. He played a lot of basketball and soccer when he was a kid in the neighborhood, but he sometimes got too competitive and angry. And so in middle school, and he was redirected to swimming, which was seen as more of a therapeutic method to channel his energy because it was more individualized sport. And also he was started on stimulants when he was diagnosed at age 8. Currently, he is enrolled at USM, and I am his PCP. He's on Vyvanse to treat his ADD and wants to switch to Adderall because it is cheaper. He has no money as a college student. He says, so he was saying this to me, and while he's talking to me and giving me his history, I'm thinking about what he has to say, because, and I need to take into consideration some of his history before I prescribe him Adderall. So from what he said, he has no history of addiction. He's a non-smoker. He drinks occasionally. He's on the swim team. He's a lifeguard engineering major. And so there's pros and cons here that I'm thinking about. So he has no history of addiction. That's great. He's a non-smoker and not heavily drinking. That's great, but he does have stress demands. He tells me that his swim, he's on the swim team. He got a swimming scholarship, and he needs to maintain good grades in order to retain that swimming scholarship. He has swim practice twice a day, once in the morning at like 6, and then the other one at 4:30 in the afternoon. He's a lifeguard to make a little bit of extra money that goes mostly towards school or costs of living. He's an engineer major, which has a lot of math and physics assignments, and so there's long hour days of demanding schoolwork. So I'm thinking about how his stress might lead to dependency or abuse of Adderall potentially, since he's swimming is stress on the body and his engineering degree is stress on the mind. So a little bit of history for attention deficit hyperactivity disorder. ADHD is a developmental condition of inattention and distractibility with or without accompanying hyperactivity. So that definition I got from Medscape. And according to the DSM-5, there are 3 basic forms of ADHD. There's inattentive hyperactive / impulsive, and combined. And a potential diagnosis, the patient must include at least 6 defining criteria for for each type to and they to be diagnosed with ADHD, and they kind of have to really interfere with the person's developmental level. They have to be kind of maladaptic and inconsistent with their developmental levels. So the criteria for inattentive ADHD form is the patient fails to pay close attention to details. They make careless mistakes in school or work or activities. Difficulty sustaining attention in tasks or play activities. They often don't seem to listen to what is being said, often doesn't follow through on instructions, or fails to finish homework, chores, or duties in the workplace. If not due to oppositional, these are not due to oppositional behavior, they're due to failure, or, sorry, these are not due to oppositional behavior or failure to understand, they just kind of don't follow through with instructions. Difficulty organizing tasks and activities, and they often avoid tasks or dislike them, like schoolwork or things that require mental effort. And oftentimes things get lost for necessary tasks or activities. Oftentimes people can be easily distracted by extraneous stimuli, and they can be forgetful in daily activities. Okay, so I think I'm recording. I paused it. Hopefully. Okay, wait, I'm gonna try something. Recording, okay. Sorry about that. Next slide. Okay, so the pathophysiology is not totally understood. Believes to be in certain areas of the brain, including the frontal and prefrontal lobes, also the parietal lobe and the cerebellum. Adults with ADHD have shown to have deficits in the anterior cingulate activation while performing tasks. But basically, these areas of the brain are related to attention and have deficit with neurotransmission related to dopamine release. Yep. Oh yeah, PET scans suggest that methylphenidate, aka Ritalin, acts to increase dopamine levels, and dopamine and norepinephrine have been known to be associated with ADHD. I thought it was funny that when I was reading this about ADHD, it said they've been known to be associated with ADHD. Like, they're a group of kids, like, yeah, they're associated. They associate together, sometimes they hang out, and sometimes they don't. Anyway, sorry. I just thought it was funny wording. Okay. Anyway, epidemiology. Americans kind of are on par with the rest of the world in terms of prevalence. It's 7 to 10% of children in America, 8 to 12% worldwide, 3 to 5 times more likely in boys than in girls, and diagnosis is usually before the age of 12. And 15 to 20% of diagnosed children bring along their ADHD into adulthood. Some adults just have residual symptoms, but overall, adults with ADHD is about 4 to 5%. So ADHD, what did I say about it? Oh yeah, diagnosed usually before the age of 12. The DSM-4 said that the onset criteria had to be present before the age of 7, and the DSM-5 adjusted it to say onset of symptoms present before the age of 12. So that's the new one. That's the new standard. Yes, sir. So let's see here. The old diagnosis. So there's the clinical presentation, which might be something that you would expect: fidgety, impulsivity, distractibility, irritable, poor concentration, higher. So these people, oftentimes people with ADHD have a higher risk of drug abuse, suicidal ideation, and depression. So, however, keep in mind that just because these are clinical presentations, some that you might think come along with ADHD do not, such as mood. Mood, there's not a lot of mood swings with people who have just ADHD. They're usually appropriate. There's some periods of low self-esteem, but the mood is not usually affected, although sometimes irritability is present, so I don't know, it overlaps with mood a little bit. Speech is a normal rate, but oftentimes people with ADHD speak louder due to impulsivity. There's no evidence of racing thoughts. That's more bipolar diagnosis. And ADHD folks don't have hallucinations or delusions. Cognition, people have trouble concentrating, and storage into recent memory. However, orientation and remote memory is not affected. ADHD can often be, can you hear that? It's my cat. She's kind of snoring in the background. ADHD can often be coupled with other social disorders like antisocial personality disorder. There's higher risk for self-injurious behavior, like I said. No, I didn't say that, but I thought it and I wanted to say it, so I'm saying it. Higher risk for self-injurious behavior. Higher risk for addiction, like to cigs and alcohol and marijuana. And there is a higher risk for someone who has ADHD to also have autism spectrum disorder as well. Symptoms of ADHD and bipolar disorder correlate, so workup should be done for both to rule out one or the other, or to not rule them out. You know what I'm saying? So rule one out or don't. Find that the person has both. That's what I'm trying to say. Okay, so causes are genetic and environmental. Genetic, parents and siblings who have it means that kids are 2 to 8 times more likely to also have it. It is found more often in monozygotic twins than in dizygotic twins, so it kind of does show a correlation between ADHD and genetic makeup. However, there's a 76% chance of inheriting it from your folks. So, there isn't, the involved genes and chromosomes are not definitively known, but they're linked to dopamine, the code. It is assumed that the genes are related to dopamine receptors. Why can't I spit those words out? So they're related to coding the dopamine receptors. The environmental causes, also kind of a gray area. So there have been studies that show connections of ADHD they're linked to toxic substances and food additive, like colors in food, while the person is in utero. There have been also links to secondhand smoke, and the role in the family environment is unclear. Some studies have shown links to how much a child watches TV or plays video games. And I just want to say, as kind of like a side story, I was going to say side story. Yeah, so I was listening to NPR the other day. That's not true. This was like a year ago. Anyway, I was listening to NPR, and they were doing an interview about ADHD, and one thing that struck me and kind of stood out in my head was that the person that was being interviewed mentioned that people who No. A race. The interview person mentioned that an hour of playing, for a child, an hour of playing outdoors, outside, is the equivalent of one dose of Ritalin, which I thought was interesting. I can't back it up as evidence based, but I thought it was an interesting interview, and I would be interested to see further studies on that and to see if really like playing outside. I mean, everybody knows that ADHD, the prevalence rates have been going up over the years, and there's theories that screens, be it TV or computer or iPads or whatever, screens might play a role. I personally think that they might. Anyway, but I didn't find any conclusive evidence of that. Myth, however, diet, especially sugar, makes it worse. Fact, no, it doesn't. So then, oops, crap. How do I go back? I'm going to pause. Help. Okay. All right. Sorry, I went to the next slide too soon, and I didn't know how to go back. But I'm okay now. So labs and imaging can be helpful, but don't offer standalone diagnosis. Labs can be done to kind of help, but they're not that helpful. So the labs that people can do are CBC with differential, electrolytes, liver function, and thyroid. Yes. And then imaging, people do MRIs and PET scans, but they're mostly used for research and not for diagnosing. Yeah, not for diagnosing. Yeah. For because diagnosis happens clinically. It's a clinical thing. So that's that. Also, there's questionnaires and performance tests can also kind of help. All this is help, but mostly it's clinical presentation, as I said earlier. So there's several kind of tests. There's Connor's Parent-Teacher Rating Scale Questionnaire, and Barkley Home Situation Questionnaire, and then there's Wender, Utah Rating Scale, which kind of looks at ADHD in adults, and all of these are just questionnaires about the potential ADHD patient. Then there's continuous performance tests, or CPTs, and those are computer-based tests that they test attention and may help to diagnose, but again, it's in conjunction with clinical information. Okay, ready for the next slide now. Treatment. The best treatment for ADHD is a combination therapy of stimulants, which are the first line and med of choice, stimulants and combo behavioral / psychotherapy. This is mostly focused on children. So, and then also combining those two things for the patient, but also looking at or providing behavioral parent training, BPT, or behavioral classroom management, BCM, environmental restructuring, cognitive therapy, also together. All of these as a combined treatment package work pretty effectively in most cases, especially the earlier you start. So, yes. So there's the stimulants are the medications of choice, like I said, and they target symptoms such as impulsivity, distractibility, poor task adherence, hyperactivity, and lack of attention. And there's a slew of stimulants that you've probably heard of most of these. So there's methylphenidate, which is Ritalin, or Metadate, or methylene ER, or Ritalin SR. And that's the drug of choice for anyone who's 6 years or older. Then there's dexmethylphenidate, which is Focalin or Focalin XR. Then we have dextroamphetamine and amphetamines mixture, or Adderall. Um, then there's dextroamphetamines, which is dexedrine. And then lisdexamphetamine, which is Vyvanse. And amphetamine, which is Dianavil XR or Avicchio. I don't know if I said everything correctly, but those are the main stimulants that are used. And then in conjunction with stimulants, sometimes depending on the diagnosis, you can also use other options such as antidepressants. And for example, another one that's used is Strattera, which inhibits presynaptic norepi transport. And then the well-known Wellbutrin and Effexor, they work on dopamine, so they can also help. You have to be careful of prescription practices because there are pros and cons. Do they help or do they hurt? They help, but you have to think about some things. For example, compliance issues are common. So because of that, long-acting stimulants have been better with efficacy than short-acting, just because they're taken once a day. So people follow that better, and they're longer acting, so they're more kind of dispensed out throughout the day instead of shorter acting meds. But there has to be routine follow-up for people who have ADHD, partially to manage the ADHD, but also, depending on the person, to look for addictive behavior as well. ADHD is associated with increase in motor vehicle accidents. So patients who have ADHD have higher levels of MVAs, but patients who are on their meds, their studies show that there's a decrease in motor vehicle accidents once they're on their meds. Same thing goes with criminal activities. ADHD patients are more likely to commit criminal activity, but if they stay on their med regime, then the criminal activity levels go down. And there's the abuse risks of the meds. So, yes. Okay, so comparing stimulants. I thought this was, so part of my scenario was Jimmy wanted to switch from Vyvanse to Adderall because he is a college student and he has no money and Adderall is cheaper. And I was trying to find a table or something that showed the pros and cons of Adderall versus Vyvanse. That wasn't too convoluted or hard to read or just messy, but that was more interesting to look at than me just saying them. So I found this, and when I was I found this table under Google Imaging, and it lays it out there for you very well, and I thought it was a good table. However, when I was trying to get the source of it, it brought me to Pinterest. So that is the source. It's Pinterest OB Peds, and that's the area. I didn't even know that Pinterest had OB/Peds area, but this is a good chart comparing, Adderall and Vyvanse, but also Ritalin and Focalin, and the major pros and cons between Vyvanse. So Vyvanse, the pro is that it's less addictive by far because Adderall capsules, the beads inside, it contains small beads and they can be crushed and snorted. Vyvanse, you can't do that. Some insurances don't cover Vyvanse, and Vyvanse has no generic option, so it's a lot more expensive, and that's big. They act in the same way. They're both amphetamines, and they both last for the same amount of time, and they both tackle, their method of action is the same. They work on the central nervous system, but Adderall's a lot cheaper. It's also a lot more addictive. So those are just two things to keep in mind. And even though it's comes from Pinterest, I thought it was a pretty good little chart there. So Adderall as my personal drug of choice to go into detail about. Wait, let me get my notes on Adderall. Notes on Adderall. Yeah, here we go. Okay, so Adderall, the dosage and uses are 5 to 40 milligrams per day, once a day. Depending on how the pill comes, you can split it and do twice a day. Black box warning, as I've said a few times, high abuse potential, dependency, and distribution to others. That's huge. That's a big concern. A prolonged use may lead to dependency. And then there's the potential for non-therapeutic use, like to stay awake. And so if I were going to prescribe Adderall to Jimmy, I would think about how he wants to focus on his schoolwork. He needs to maintain his scholarship. He has these swim practices all the time, so he's probably tired and wants to stay awake. Also distribution to others. So Jeff asked us to focus on 2 to 3 adverse drug reactions or common side effects. There's a million for Adderall that are worth mentioning. So I have to do more than 2 to 3 because they are things that really you should be concerned about. So adverse drug reactions, there's cardiovascular events. There's all sorts of things that it can do to your cardiovascular system. So like I said before, one of the key ADRs is dependency or abuse, but there's also depression, cardiovascular issues, Stevens-Johnson syndrome, seizures. Yeah. Oh, yeah. So cardiovascular issues. Sorry, I skipped a little part of my notes. Such as MIs, stroke, severe hypertension. Then there's Stevens-Johnson syndrome, which is not a cardiovascular issue. Seizures, but then anaphylaxis can happen, priapism, and then withdrawal symptoms if you discontinue it abruptly. And then some of the common side effects are anxiety, tachycardia, tremors, diaphoresis, hypertension, paresthesia, and dysphoria and euphoria. Either one of those can happen. Contraindications / warnings are basically, it's contraindicated in people who have cardiovascular issues. Yes, if you use that brain, then you might come to that conclusion. And then there's arrhythmias. People with arrhythmias don't use these. And then hyperthyroidism, drug abuse history, psychosis, bipolar disorder, Tourette's, and seizure history. So I thought Tourette's was interesting, and so I looked up why Tourette's, and apparently Adderall and other stimulants can increase the tics in Tourette's. So pregnancy and lactation, no, and varies. I'll go into a little bit of depth there. Pregnancy, no, don't use it during pregnancy. Adderall during pregnancy, there's a risk of teratogenicity, which I did not know what that meant, and it means malformation of the embryo, neonatal complications, premature delivery, low birth weight, and neonatal withdrawal symptoms. So all of those can happen from using Adderall during pregnancy. Lactation, what I found there was safety is conditional, so safety may vary with different populations or dosing. So I translated that to mean that there hasn't been a lot of studies of people who use Adderall during lactation, thus be careful. Yep. Okay, pharmacokinetics. The mechanism of action is kind of unknown, but it stimulates the CNS activity and blocks reuptake and increases release of norepinephrine and dopamine in extraneuronal space. Extraneuronal. I think I added a syllable in there. Anyway, the absorption is well absorbed within 30 to 60 minutes, metabolized in the liver via via some enzymes. Glucuronidation, that's one way that it's metabolized, and then the enzyme is CYP450 monooxygenase. Anyway, it's metabolized in the liver. Half-life is 9 to 14 hours depending on one's age, and excretion is through the urine, but it's pH dependent, which I thought was interesting. And client teaching plan. So in discussing potentially prescribing Adderall to Jimmy, I would talk to him about his concerns. I would want to hear about his concerns about cost, his situation in school, social and personal priorities, so that I had a better idea of where he is with his ADHD, his thought process for Adderall, and kind of see if there are any red flags that stood out to me. I would emphasize the high risk of abuse, dependency from Adderall, and I would also, since there are so many advanced drug reactions / side effects, I wouldn't go over maybe all of them with him, but I would talk about cardiac issues, priapism, anaphylaxis, withdrawal symptoms if suddenly stopped, hypertension, paresthesia, Stevens-Johnson syndrome, dysphoria, and euphoria. So I might just kind of alert him to those, to be aware of those, and then I would talk to him about a plan for regular follow-up visits in conjunction with psychotherapy if needed. He's 21. He's no longer a child. So since I said before, only 15 to 20% of children with ADHD bring it into adulthood, and so I would kind of monitor for signs and symptoms of where he is with his behavior, with behavioral issues. It doesn't really seem like he's had that many behavioral issues, but I would look for them, and if so, maybe work in conjunction with a therapist if needed. I would also monitor for signs of abuse, withdrawal, behavioral changes in general. And here are my references: Hippocrates and Medscape, and Pinterest, because of that table that I found. So those are my references. I do want to say that I also, because I wanted to get creativity points, I made an alternative PowerPoint presentation that I'm submitting to Jeff to put up on Blackboard, and it's inspired by James McCormick. And I made a similar video, well, not nearly as good, not nearly as professional, but a similar video to James McCormick's themed videos, and I did a kind of like song called Let It Be /ADD. So if you're interested in watching that, feel free. Thank you so much for listening.